Record PE for Pharmacoepidemiology, Elevate RWE reporting. Welcome! In this micro-lesson, we're demystifying Record PE, the reporting guideline for pharmacoepidemiology using real-world data. Clear, transparent reporting of real-world evidence, RWE, builds trust with clinicians, regulators, and peers. Record PE is a targeted extension of STROBE, adding what epidemiologists need when studies rely on databases, claims, or registries. When you follow Record PE, your analyses are easier to reproduce, your peer reviewers can follow your decisions, and readers can judge validity. Think of it as a practical checklist that turns a good study into a credible, audit-ready one. Start with the basics. Clearly name the databases and the exact time window used, for example, 2016 to 2023. Explain how data are captured, cleaned, and updated. Are prescriptions recorded at dispensing or prescribing, and how frequently are refreshes released? Describe population coverage, national, regional, insured lives, and any linkage to labs, mortality, or registries, including match methods and success rates. Be upfront about strengths, size, longitudinal follow-up, rich clinical detail, and limitations, missing over-the-counter use, out-of-network care, lag times. Readers must see what the data can and cannot support. State your design explicitly. Cohort, case control, self-controlled case series, SCCS, or another justified approach. Define the index date and the time at risk windows so timing aligns with biological plausibility. Clarify whether you used a new user design, preferred to avoid bias at treatment start, or a prevalent user design, justify why, e.g., chronic therapies. Include a conceptual diagram showing exposure, washout, covariate assessment, and follow-up. This picture helps reviewers spot misalignment, overlap, or gaps in time anchors that could distort your effect estimates. List inclusion/exclusion criteria with the exact codes and logic, ICD, procedure, and drug codes, plus look-back periods. Define exposure precisely, how you construct treatment episodes, allowed gaps or grace periods, stockpiling rules, and switching or discontinuation. Provide the algorithms and full code lists used to identify drugs and conditions, and cite any validation evidence, positive predictive value, sensitivity, or internal checks. The goal is that another team could rebuild your cohort and exposure episodes and arrive at the same analytic data set. Specify outcome definitions with exact codes and any required settings, inpatient only, primary diagnosis, and report validation metrics if available. Explain how you chose confounders, whether a priori, domain knowledge, or data-driven, high-dimensional selection, and what time window you used to measure them. Describe your adjustment strategy, propensity scores, PS, inverse probability of treatment weighting, IPTW, matching, or stratification, including balanced diagnostics. If exposure or covariates change over time, address time-varying confounding via methods like marginal structural models or time-updated PS. Name likely biases up front. For example, immortal time bias when follow-up begins after exposure is confirmed, or misclassification of exposure/outcomes due to coding. Explain how you prevented or quantified them. Describe your missing data approach, complete case, multiple imputation, missing indicator, and the assumptions behind it, missing at random versus not. Pre-specify sensitivity analyses, alternative grace periods, stricter outcome definitions, shorter/longer time at risk. Include negative control outcomes/exposures to detect residual confounding, and report what would change your conclusions. Report your model types, e.g., Cox, Poisson, logistic, fine gray, and key diagnostics, proportional hazards checks, overdispersion, influential points, and PS balance, standardized differences. Present effect measures clearly risk ratio, RR, hazard ratio, HR, or odds ratio, OR, with confidence intervals and, when possible, absolute risks for context. State how you checked assumptions and explored heterogeneity, subgroup analyses, interaction terms, or random effects meta-analysis across data partners. Make it easy for readers to see if results are stable or driven by specific strata. Use the Record PE checklist to structure your manuscript, and borrow template wording where helpful for clarity and consistency. Provide full code lists, an attrition flow diagram, and a sharing plan for protocols and analysis code, noting any privacy constraints. Clearly state generalizability, who your findings apply to, and any data access limits that affect replication. Bottom line: transparent methods and thorough reporting elevate credibility, speed peer review, and help decision-makers trust your real-world evidence.